My name is Richard Spaulding. I'm a cardiologist in Houston and chair of the committee. I want to introduce two new committee members, Dr. Jamie McCarthy on the far left. Jamie, you want to tell them a little bit about yourself?
Thank you. I'm an emergency medicine physician at the University of Texas in Houston and co-chair for the CETRAC Cardiac Care Committee and actively involved in cardiac care for as long as I can remember now, I think.
Jamie's on the National AHA EMS Committee for acute cardiac care and runs an outstanding outfit in Houston. Dr. Tim Mixon had a two-year vacation, I guess, and has returned to us. Tim, you want to tell everybody a little bit about yourself?
Sure. Hi, Tim Mixon. I'm an interventional cardiologist, work for Baylor Scott & White in Temple, and have been involved in STEMI systems of care in our place and around the state. Served on this committee a few years back and have been off, and then as well have been involved in my local RAC and have served as the chairman of the acute care committee for that RAC.
So why don't we go around the table? Robert Wozniak is to my left. For some reason he didn't get a name tag, but he hasn't been voted off the island as far as I know. Robert, why don't you tell everybody a little bit about yourself?
I'm Robert Wozniak, interventional cardiologist here in Austin, and have been working as the co-facilitator for the CATRAC here, and working closely with this committee for at least 4 years now, and I think that's enough.
I'm David Wampler. I'm at UT Health Science Center in San Antonio, and I'm the sort of the clinical research director for the Office of the Medical Director, San Antonio Fire Department.
I'm Neil White. I'm a registered nurse and licensed paramedic in Abilene, Texas. I'm the Director of Operations for Metro Care Ambulance.
Christine Newhouse. I'm a nationally registered EMT PASIC for over 30 years. I'm a RN, also a flight nurse, and I'm a regional nurse coordinator. I help set up STEMI and stroke programs across the United States. I work for Air Evac Life Team.
Hi, I'm Craig Cooley. I'm emergency medicine faculty at the Health Science Center in San Antonio and one of the associate medical directors for the fire department.
Todd Haugen from El Paso. Been a paramedic for longer than I care to admit. Currently working for Las Palmas del Sol Healthcare in El Paso.
Thank you all. Well, unfortunately, Catherine Bissell has fallen ill, and Lonnie Den is traveling. Lonnie is first up on the agenda, and in her place, we're going to have Stephanie Chapman from the AHA give us a discussion on the action registry results. Stephanie.
Thank you, Dr. Snelling. Is that working? There we go. So I come to you from the Board of RAC just real quickly, a little bit about us, a little bit unique. We have 3 counties in Texas, but we also cover 8 counties in New Mexico, 9 primary PCI centers. We have 7 of them in the regional report, 1 in New Mexico. We have about 200 STEMIs annually. And we have a unique population, 72% Hispanic, 39% diabetic. Even despite those statistics, according to the Texas Vital Statistics Unit of DISHES, this region in Texas has mortality rates that are statistically significantly lower than the state rate for ischemic heart disease, heart attack, and heart failure, while reporting average rates on hypertension, smoking, and inactivity. So that's all I'll tell you about us. And we'll just do a quick action registry, get with the guidelines update. For those of you who don't know, Action Registry is the National Heart Attack Registry housed at the ACC. It's jointly owned by the American College of Cardiology and the AHA. There are 134 hospitals participating in the registry as of earlier this week. About 50 of those right now are participating in the Texas Heart Attack Data Collection Initiative. Q3 reports were late, but they have landed in the web portal. So if you've been looking for your Q3 report, it is there, as well as any regional reports you're part of. There is not a state report for Q3. So there was a recent update, January 1st, to Action Registry. The changes are additional pre-hospital data elements to first medical contact fields and non-system reasons for delay that will actually exclude patients. When the Q1 reports drop, we hope that the Mission Lifeline Regional Report will reflect those changes. So the new pre-hospital fields, this will just allow us to break down the timing a little bit more. EMS dispatch date and time, EMS leaving scene date and time, agency number, run number, and then cath lab activation date and time. That'll actually allow us to see whether or not the cath lab was activated in the field. The first medical contact, now we were using auxiliary 4 to identify non-EMS first medical contact. Now it's an actual field. So if a patient is coming from urgent care or the physician's office, we can record that and exclude them from the 90-minute measure. There's also a new option for non-system reasons for delay. The only 2 acceptable reasons right now are cardiac arrest and intubation. Those will also exclude the patient from first medical contact to device in 90 minutes. There is a new version of the Action Registry form available. This is really exciting. It's the first time that ACC has allowed hospitals to only capture their STEMI population. So registered site managers can go in and choose, if you're using the limited form and not the premier form, they can actually capture only their STEMI patients. This is encouraged for hospitals new to the registry who hadn't signed on because of the data collection burden, and also those who are sitting with a contract but not using it because they don't have the staffing. Hospitals will still be eligible for Mission Lifeline recognition. They will not, however, be eligible for the Action Registry recognition that the ACC does. So these are the pre-hospital data elements that were existing. Nothing has changed. This is just a list of what we had before and what will remain in the tool. And then finally, it is time for Mission Lifeline EMS recognition. The deadline to apply is February 28th. We're looking to EMS agencies to report on 3 STEMI measures. Patients with non-traumatic chest pain, 35 years and older, treated and transported by EMS who receive a pre-hospital 12-lead ECG. Percentage of STEMI patients treated and transported directly to a STEMI receiving center, PCI within 90 minutes or less, and the percentage of lytic-eligible STEMI patients treated and transported to a STEMI referring hospital for lytics with a door-to-needle time of 30 minutes or less. If an EMS agency is only transferring to PCI centers or only transferring to referring centers, they don't have to report on the measure that they don't use. Again, applications are encouraged by February 28th. That is the absolute deadline. We'd love to recognize as many EMS agencies as possible, and there's no fee for applications. And that's all I have today. Thank you.
So is there no update on the data results?
Not at this time. I think that'll come from dishes.
Okay. Any questions for Stephanie?
I have one quickly. Stephanie, how many of so if only 50 are currently signed on to report to the state, and is that increasing or has that been fairly static?
I believe it's increased by about 10 over the last quarter. I know just in my region they're struggling getting the paperwork through legal, but their intent is absolutely to participate. I haven't had one hospital say that they don't want to do it. It's just a time-consuming process.
You mentioned the state report. What was the reason for that?
That's based on the dishes set up a schedule with NCDR based on funding.
So what is that schedule?
I think it kind of, they determine it as they go. There was a Q2 report, and that is available in the web portal. There just wasn't a Q3 report. So we certainly anticipate Q4, hopefully.
But this is with broader representation. We'd have a much clearer understanding about what's really happening at the state level. It would give us the ability to do this. In that sense, for those of you who, I would just encourage you, we're having trouble locally in Houston convincing some of our institutions, but it's mostly the legal folks. But I think worth finding out if your system is reporting, they're allowing their action data to flow to the state. It's all in a blinded manner. Would encourage you to encourage find out where the soft spots in your facility to do that, because the more representation, the better this report will be for all of us to use.
Absolutely.
I recently met with our chief medical officer of a hospital system, and he claimed that the individual hospitals are free to participate. They have no problem with sharing the data. So I've just had to meet with our CEO of our Heart and Vascular Institute, and so we'll see how fast we can move over. Anything else? Thank you very much, Stephanie.
Thank you.
So it looks like next up is a report on the STEMI data collection proposal and potentially funding of that. Same as Neil's not here. Are you going to be the report to you, Robert, or no? Neil's? Oh, Roberto. Okay, sorry.
No, that's okay. Good afternoon. I'm Roberto Rodriguez. I'm the medical officer for the Health Promotion and Chronic Disease Prevention section. So I'll be talking a little bit more about this statewide data report. As a reminder, this funding was appropriated during the last legislative session to advance heart attack and stroke reduction efforts, and the council has launched this statewide data collection initiative. It depends on voluntary participation from hospitals that are enrolled with the Get With The Guidelines data set. And this data is protected under HIPAA. Our analysis is limited to aggregate data analysis, and it's intended to inform stakeholders of opportunities for collaboration and system enhancement. This goes a little more into some specific goals related to understanding the prevalence of heart attack and stroke in Texas, evaluate both pre-hospital components of the systems of care as well as treatment in facilities. We anticipate that this will help us assess policies and practices regarding to the delivery of care across the state, identify areas of opportunity for quality improvement, and also recognize the collective achievement of hospitals in Texas. So for this first data report, again, this has been a process of recruiting hospitals for participation. So at the time of this first data download, we had information from 44 participating hospitals from the time period of October of 2008 to June of 2014. These hospitals were distributed across 30 Texas cities and mostly represent urban and suburban communities. The performance measures that were evaluated for this report are listed here and were chosen with the input of some data analysts, or excuse me, data consultants to Dr. Rutledge, some of whom are on this committee. So in terms of general findings, you can see that for this time period, among this population of hospitals, there were about 27,500 individual episodes of care for heart attack. About a third were STEMI. Close to 60% of patients were transported to the hospital by private vehicle, and over 3/4 received their first EKG upon arrival at the hospital. Looking at the measure of EKG within 10 minutes of first medical contact, you see that on this first analysis, about 28% of eligible patients did not meet this performance metric. We also looked at EKG within 10 minutes of arrival, and for this performance measure, 35% of patients did not receive an EKG within 10 minutes. The patients included in this measure were not stratified by mode of arrival, so it included both EMS or direct presentation. And obviously, if they received an EKG prior to arrival at the hospital, they were also excluded from this measure. We also utilize the Mission Lifeline because participants in this data collection initiative, we do get a statewide report for those participants, so we also use some of the data points for the Mission Lifeline report in this first report that has been published. And by the way, I forgot to mention that this report you all have copies of and is downloadable also on our website at DISH's. For these slides, the overall system is captured in the first bar, and then individual participating hospitals are represented in a de-identified way as subsequent bars. So for the measure regarding EKG within 10 minutes of arrival, this is specific to Q2 of 2014 versus the previous data, which was the cumulative data from 2008. You can see that about 77% of patients who arrived by a personally operated vehicle received an EKG within 10 minutes. And that ranged from a low of about 31% at some hospitals to 100% at several hospitals. That's just continuation to show the variation. We also looked at time from first medical contact to PCI, and the national median time for hospitals in the Mission Lifeline program is about 80 minutes. For this representation of Texas hospitals, it ranged from 41 minutes to 120 minutes, and the average was 76. You can see also the range by facility there. And I believe finally we looked at PPCI within 90 minutes, and there you can see that among eligible patients, over 94% received PPCI within 90 minutes, and the median time was 60 for STEMI. Sorry, one last measure looks at transfer time. As you all know, we have about 154 PCI-capable hospitals in Texas that are STEMI receiving hospitals, and looking at transfer from a referral hospital, the median time spent waiting in the emergency department until discharge to another hospital for PCI was 45 minutes, about 45 and a half minutes among 62 eligible episodes of care. So again, just want to reiterate that this first report reflects about 44 hospitals. We're now up to about 50 hospitals. We are getting the data downloaded on a quarterly basis, so we'll have quarterly reports that will be made available on our website, and we are very much hoping that we get more hospitals to sign up.
I have one question about the how it's structured. I know, for example, in the regional reports, there's a one-time setup fee. Those regional reports are set up. If other hospitals join them, they would essentially have to recreate the reports. How's that going to be handled, as it seems like hospitals are going to be slowly added to the system? Can y'all immediately on the next quarterly report?
Yeah, it's a fairly streamlined process. There's it's basically Carla can probably speak to this better than I can, but as I understand it, there's forms that get submitted to us, and that automatically allows DSHS to access the data on the next download. So there's very little lapse in terms of once they sign and consent to it, we get the data, access to the data for the next download.
So the plan is for quarterly reports. So I still didn't quite understand why this quarterly report, the second quarter report, wasn't. Is that a different? Okay.
You're talking about.
Yeah, so what I mentioned was the Mission Lifeline regional report, statewide report.
Okay.
This is data that the state is actually down here.
Okay. Sorry.
This is very similar to what we've seen presented before at the previous meeting in November. What the take-home message for that from that report to me was that basically the PCI centers are performing well, and the sweet spot for improving overall STEMI care was in the STEMI receiving hospitals and in the field in terms of recognition of the ECG, basically performing ECG recognizes STEMI, activating from the field, giving fibrinolytics when transport times are going to be long, or if you couldn't get a PCI in a timely fashion. And none of those metrics were really acceptable. Has anything changed in the interim, or is it just pretty much the same?
In terms of the actual measures that we're
Yeah.
going to be looking at, going forward with the input of Dr. Wozniak and Hillert, we're actually expanding the measures that we'll be looking at for the next report. So we can get back to you exactly what those measures are. I don't have them in front of me, but we did share that with the data consultants to Dr. Rutledge.
Then there was another survey that was performed independent of this, right? This is just analysis of the action registry, but there was a RAC survey.
There are quarterly RAC surveys as well, correct.
And do you have any information regarding recent the RAC survey?
We don't have, I did not bring the report, but we do have the same, all of these were published and they're on the website. So we do have the reports from the most recent RAC quarterly survey as well.
So
we can send that to you as well.
Can you shoot us the URL for that? Okay. So what we have identified collectively is the issue about pre-hospital ECGs being one particular thing, and there's a wide diversity in terms of the EMS systems that actually have pre-hospital ECGs, and it would be very helpful to know what the penetration is in the communities across Texas, what the gap is in terms of systems that don't have them, where they are, and some sense of whether they would use them. And the other bit of information that would be very helpful is, can they transmit them? So it seems like you not only have to have them, but you have to be able to transmit them. And what the barriers are to transmission of those ECGs, and how could that be remediated? So that's sort of the area where we thought that there might be some opportunity to improve outcomes.
So, as our charge is to try to improve the healthcare or cardiovascular care in Texas, one thing I'll point out, and we mentioned this at the other meeting, was that these are hospitals that voluntarily submitted their data, and this may be the best of the best. And so we're scoring high for the places that want to show off their data in some fashion, and are organized enough to have data to report. But this certainly is not encompass the cardiovascular health of all of Texas. So that's I think that's a point I'd like to make sure that we keep driving that point, and so that's what our job is, to represent the entire state. I know that there's work in requesting more funding for going forward. Do you have any thoughts on how you would like to see this mature with the more funding if you were king for a day, and how you would do this, and how you see that you could best get the most value for that funding?
Thanks for not putting me on the spot. I think we have tremendous capacity at DSHS for analytics, and I think I don't anticipate that we need a huge additional amount of money to continue to do really meaningful data analysis. I think really our big challenge is kind of selling the kind of population health benefits of this type of activity, and we're hearing from hospitals that they don't see the benefit. What's the public health benefit? They don't kind of get that, and so I think if anything, just funding to enhance recruitment. I don't know if that is financial incentives for hospitals to participate. I don't know what that is. That's, but that might be one consideration.
So that's interesting. One other thought that has been kicked about is best practices. There are a number of STEMI systems that are relatively mature around the state. And there might be best practice models that could be disseminated to areas that don't have knowledge of what can be done, what the possibilities
Right.
are,
Sure.
and how those systems matured and actually came together. And then the vehicles for that is a Iraq-based training. Should it come through other agencies? And how much funding would that require? That would be helpful to know. So on this committee, we have people who represent areas that are less populated, and Christine, you, not to mention any names, but tell us a little bit about Corpus and how that works.
So it was interesting when we got the survey in Corpus and Iraq, and I don't see, there they are, they're here. Hillary is our executive director. And so we answered the survey and we've been collecting our data, but what we're finding, and Hillary, please correct me if I'm wrong, is that we don't get a good representation of what's actually out there because not very many of our services are reporting to us.
Necessarily the data. So the assumption is if the numbers didn't match, that meant we didn't have the information versus it was over a certain time frame, it was a different time frame. So in discussions with Carla to look at maybe redefining some of the questions to make sure we get everything. Because like she said, well, but not all of yours had an EKG in less than 10, had an EKG at all. And I'm like, well, it's because you asked me if they transmitted it. Well, they did do the EKG within 10 minutes, but they don't have the ability to transmit it because their machine is not upgraded to have transmission. So she was like, oh. So I think there have been some questions over this first year of collection of data for Rider 97, at least from the RAC perspective, that we can clean up to get better data because it has been a little misrepresented as we're moving along, at least for our region.
Any other?
I'd say that, one other area that clearly is an area for, I think, system and opportunity is, as Dr. Smalling started to mention, was the transfer patients, and anything that we can gain from the data to help us better understand where the gaps there are. We have the reporting a median time of 46 minutes, and the data that was published or presented at AHA this fall from the STEMI Accelerator project that many people in this room participated in at the RAC level, demonstrated that once you crossed 30 minutes in an emergency room, your mortality started to climb, and it doubled by 45, and then another significant increase by the time you got beyond that period for 45 to 60. So you went from a 3% to an 8% to a 12% mortality just ticking away in the emergency department. So that's clearly an area that with this would ideally some focus on to better understand where those barriers are.
So I think one of the sort of creative mechanisms to get hospital participation is like I see the chair of my cardiac committee here put a EMS director in charge of your cardiac committee. And that's a great way to encourage the facilities to participate in your program when the leader of the committee really has the power to decide where his patients go.
I guess one thing that I've learned from the years of working on STEMI systems of care is that a lot of this is solved just with effective communication. Because, there's a lot of common sense out there, and your ideas are awesome ideas that and you may not have the opportunity. So perhaps this is such an important piece of the data. I wonder if it's something that we could put on our agenda as every time we meet, that we're talking about where we are, and we can continue to try to improve it. This is sort of version 1.0, and that you may come up with ideas, or others out there come up with ideas as far as trying to improve upon, whether it be better questions, faster turnaround times, or so that's what I would think. I think this is a really this drives a lot of the stuff that we do as far as are we running in the right direction or not. So, and it's hard for you to do it from your perspective. It's just like I can only understand it maybe my limited area where I actually am involved with that patient's care. So I would think this is valuable, and I think you started somewhere and you broke the ice, and now we just keep moving. So
I think in the last quarter, there have been at least 2 major publications, I think of last month actually, that reported on large numbers of patients who underwent fibrinolytic therapy followed by direct transport for PCI, and the outcomes being far better than delaying PCI. And so that's one thing that could be done, is to make that information available to the people that are out there taking care of them. I mean, if your patients had chest pain for 45 minutes and you got, a 2-hour transport, they're not going to get better with a PCI. They may stabilize, but they're not going to get any better. They're going to save heart muscle. But if you can get the lytic into them, by the time they get there, they may well be refused, and you may have their infarct size. So I think this is a real important opportunity for us to disseminate that. And I apologize because I meant to forward those articles to Catherine and Dr. Wozniak and Dr. Cooley to consider.
Smalling, I attended a statewide meeting with the American Heart Association in the state of Arkansas, and there was one report that was already out that did show that the outcomes were extremely good with the fibrinolytic on board with PCI. And in the room where we were at, there was not another person except one other EMS person who knew that those outcomes were improving. So those articles, if you could get them posted somewhere where we could share those would be awesome.
Well, and I think this touches on where we may want to go with the next part of this. I forget who mentioned, but the PCI centers in general have got the system pretty tight. We're fighting for 2 or 3 minutes at a time kind of stuff. And I found it very telling, the slide about the median time for transfer. As someone who's worked in, and as others in emergency medicine in outlying areas, that's about right. It's kind of like that EMS time warp. You think you've done an amazing job, and you've not stopped to breathe for the time that you're getting that patient, whether it's a trauma patient or a STEMI patient out, and then you realize you had them in your department for an hour. And there's just lots of factors that go into that, and I really find it hard to believe we'll ever make significant enough improvements on that, except for referring centers that may be just down the street from a PCI center. And the fact that some of us have been doing this long enough to remember back in the days when you had to fight them to accept the transfer because you gave them lytics because they were scared to take them to the cath lab, and they clearly we're way beyond that. But there's a generation, I think, of EM providers out there that are uncomfortable giving lytics for STEMIs. And through the publication of the research, and I think pushing from this committee and things out, that may be where we can make a lot of headways, particularly in the more rural parts of the state.
That's the exact challenge we have in Abilene, is getting the rural facilities to get those patients out in a timely fashion. They're holding them for 2 and 3 hours before they even make the call to transfer them in to a PCI hospital. Once they're there, the cath happens very, very quickly. It's pure challenge of getting the rural hospitals to get them to even notify the hospital that they need to get a patient up, and we fought that for the last year solid, and still not able to make a whole lot of progress. So I'd really love to have those reports to take out as basically some more ammunition.
So that's one of the reasons in our RAC, since we do have facilities that are over 100 miles to a PCI center, that as a RAC, as a region, anytime there's a delay of over 30 minutes of transferring the patient out, then that's a referral to the RAC so that regionally we can look at those, track those, and see if there's system improvements that can be made to help those rural sending facilities.
Have you guys found specific things that help?
Not yet.
So while, I agree with everything that's been said, but some of the delays are in urban centers where the PCI center is down the road, is a 15-minute walk, and some of those are access to transport EMS and not having not having an ambulance on standby at a hospital or available, and the smaller the facility, the less robust their contract is going to be with private ambulances for expected time to arrive to transport an ALS patient. Southern California has solved this with just rolling 911 into their transfers. If you're in a non-PCI facility, you call 911. The triage nurse calls 911 when a STEMI is identified, and LA County comes and picks you up and drives you to the right hospital.
Anything else, Roberto?
No, thank you.
Thank you so much. Thank you. So, next up on the agenda is a report from the Caruth 2 Heart Attack Awareness Initiative. Wendy Sechrist is going to be giving that for Shanti.
Thank you. Yep, Shanti and I look slightly different, so you won't get us mixed up. Okay, so I'm going to review quickly. I'm sorry, my name is Wendy Sechrist, and I'm the Vice President of Quality and Systems Improvement for American Heart Association, and was very fortunate to be a part of Caruth 1 and Caruth 2. I'm going to give a quick background on Caruth 1 for those who aren't familiar, and then talk about really this communications and consumer outreach campaign, because as was mentioned earlier in the data today, we think there's a lot of power that's derived when this data is being collected, because then we can find gaps. It allowed us to get a subsequent philanthropic grant, which we were told we weren't going to be able to get. So we believe really the power of the data is what's going to also set us up for success in future legislative sessions for filling gaps and helping advance our STEMI initiatives. So in 2010, this was when our first Caruth grant was written, and it was to the W.W. Caruth Jr. Foundation, which is part of Communities Foundation of Texas. And in 2010, the best data that we had said that about 30 people a day were suffering a heart attack. And we knew that our door-to-balloon numbers looked good. We had pockets of really great EMS care and hospital care, but there wasn't something regional or system-wide. And so our application was successfully funded at $3.5 million, and we were able to use that just geographically within the boundaries of Dallas County. That was the limit of the grant. So we had 15 hospitals and 24 EMS agencies that were all providing data. We filled equipment gaps with EMS, 12 leads, making sure that they could transmit. We conducted a lot of education. We developed more protocols. So it's actually very similar to the work going on in other regions in Texas that are already doing, like CATRAC, CETRAC, STRAC, already doing Mission Lifeline, similar work, but it was ramped up on steroids and had funding to fill equipment gaps and get a deeper dive into the data. And I did want to mention that I know since Dishes is able to download the raw data from Action Registry, they can slice and dice data, and so they should be able to look at things like zip codes and are there areas of the state that we need to put more funding into the RAC to help in these initiatives. So that's something we'd be really excited to see. What I just wanted to show was really quickly some of the outcomes, and what's important on this slide is looking from we had a two-year period of data that was collected, and so these are the 15 hospitals, and like I said, as you can see, most of them are still treating mostly to the target, so their means were very close, and the medians were a little bit more scattered, but what we were really excited was over the 8 quarters how everybody came more consistently down towards the target. So our means and medians were getting much more closely aligned with the target and overlapping, which meant we had less variability in the patient care. So we were really excited again to see the good work going on in Dallas was getting even greater. And so this is a summary of the outcomes that we really studied, and the priority that we looked at was symptom onset to arterial reperfusion, or the first SOAR metric you see up there. So we knew in Dallas County we had certain metrics, but we wanted to see, we couldn't say we knew exactly what the total ischemic time or SOAR time is in our region. And if you look at that, we only improved about 5%, which is what you're going to see led to Caruth 2. But we were really excited to see that not only did our door-to-balloon, we started off and maintained that really well. And actually, even in the Mission Lifeline reports now that have expanded, we have 35 in North Texas who have signed on for that. Our door-to-balloon metrics are still really holding well. But the two areas we were most excited to see gains were our first medical contact to balloon, where we dropped from 133 minutes to 91 minutes. So 42 minutes we were ecstatic about. And actually on the latest quarterly report with Mission Lifeline, we're at 77. So we're, again, excited that that data is holding 2 years afterwards. And then the other area, again, our cath lab is consistently in guidelines time. But the other area that we're publishing and seem to get good feedback on is the door-to-balloon minutes saved with the EMS cath lab, activation. So this is one of the first studies we can see that actually was tracking that time was saved within the hospital door-to-balloon time when EMS was activating or working with their hospital to activate. So even in Dallas, we had a few physicians reluctant to activate the cath lab when EMS was calling a suspected STEMI. And so the data was showing us every quarter that we were getting stronger, and it was we were kind of knocking down some of those walls. So I do have this presentation. I'm happy to email it to anyone, but we have been publishing, so we've got at least 5 publications off of that data, and it continues to be mined. So in Caruth One, we also had funding to conduct market research on all the patients and families who did not call 911 because we were still below the 50% average. And issues that were uncovered won't surprise anyone in the room. I think of 911 for fire and injuries or traumas. I don't want to look foolish. I didn't know how to describe something in English. And so 3 primary concerns arose from all the interviews and all the market research we conducted as a part of that group. The ambulance was not considered a point of care and looked at as more of a glorified taxi. The first responders are not regarded as medical professionals that had the right skills, and there was very little awareness that the hospital and EMS were actually communicating and that care was actually beginning in the field. And then we also had another study come out last year that, again, 56% of people say that they would do something other than call 911 when they were first experiencing the signs of a heart attack. So we went back to Caruth and the Communities Foundation of Texas to specifically say, okay, you gave us resources, and the providers in Dallas County really came together and strengthened a really great regional system. Now we need to get the consumer there. We need them to understand the signs, and we need them to act on it. So it's actually not an awareness campaign, it's an activation campaign. It's actually up to $5 million. Caruth has given us $1.7 million up front, and will increase that up to 3.1 when we match 2 million. So AHA staff is having to go out and solicit additional donors, or if we're selecting print ads, we want to buy 3, we want to get 1 donated. So we're required to get up to $2 million in match as part of this. But the campaign is really based on don't die of doubt, trust 911. Quit second guessing yourself, and really directly addressing some of those concerns that came out of the market research, and saying that calling 911 is still the best thing to do, and that it's going to get care started more quickly. So the vision of the campaign is really not AHA coming out with a message, but AHA working with all the healthcare providers so that across North Texas, and we were successful in asking that we break our boundary of Dallas County. So it actually includes all of North Texas. So we're sharing these resources with EMS agencies and hospitals so that we all have a unified message on heart attack and the activating 911. So now we're getting into the part of the campaign, which is really communications expert piece. So I'm hoping you don't have good questions on the communications part, but I'll give it my best shot. Our target demographics are baby boomers, the responsible generation, and then because of our population in Dallas, which I had never heard this word before, but the mid-acculturated or second generation Hispanics, people who live in family and homes where not everybody speaks English. So it's a 2-year multimedia marketing plan. So the campaign kicked off about 4 weeks ago and will run throughout 2015 and 2016. And we're hitting TV, outdoor, digital, print, media, online. And the objective is that in the first year alone, we'll hit over 102 million impressions, which is the way that communications folks measure their impact and the reach of their messaging. For us, I can tell you that with the Don't Die of Doubt campaign, what I'm most excited about, because my angle is not communications, is that we're continuing to get data from the hospitals and EMS agencies over this 2 years. So we'll be able then to compare apples to apples from our Q3 2010 when Caruth 1 kicked off. And even though we had this 2-year gap, the metric seems to be holding. Now we'll actually be able to see if we can achieve 2 things. One, that the consumers actually activate 911 more often, so we have a higher % arriving by EMS. And secondly, that they shorten that total ischemic time, that they're activating the system much more quickly on the warning signs and symptoms. So this is actually, I think, as far as our lit review has shown, it should be the first one that shows the impact of a communications campaign across those 4 years on the healthcare provider network. So this is, you're going to see just some examples of some of the materials. So Don't Die of Doubt television, and I'm not sophisticated enough to show you the TV ad right now, so I can tell you it's on YouTube and give you the links. But here are some of the print ads. I would feel foolish calling an ambulance if I wasn't certain. And everything ends with the heart attack, ? Trust 911, don't die of doubt. And you'll see AHA's logo on here, but the hospitals and EMS agencies also are able to co-brand this when they signed on in North Texas. I didn't know driving myself to the ER would delay treatment. My mom thought she had indigestion, billboards, websites, and it's actually don'tdieofdoubt.com. So we have our American Heart website, which can be its own beast to deal with. We also have a Caruth One website, but we wanted something just for the consumers in North Texas to access this material. So this actually does link back to all the other AHA materials and support, but it's a specific portal that we're trying to see what is the reach of how many consumers are actually going to this website. Just some more images from the website, and then samples of how we're working with our healthcare partners. And obviously with the hospitals having marketing departments, they've got the better, the structure to more easily leverage this. But we are working with the EMS agencies when they're doing community newsletters or with EMS Week coming up to say that they're partnering in this heart attack awareness and survival activation campaign. So the image or the vision is really to get all of North Texas with a unified message on activating 911 if you're having any type of chest pain or heart attack question. So we will be giving EMS agencies and hospitals brochures. They've got access to posters, all sorts of web banners. And to date, we have 32 of our 35 hospitals in North Texas who have actively signed on to share these materials and commit to making sure that they're submitting data over the 2 years. And it's just an odd coincidence. We also have 32 EMS agencies because the numbers change daily, but as of yesterday, we have 32 hospitals and 32 EMS agencies. And then these are some of the items the hospitals and EMS partners are able to use. Again, recognition, testimonial videos. We will be doing a lot of work, especially in year 2, on survivor stories, trying to personalize these issues. Because again, the majority of the market research came back as, that happens to somebody else, but it wouldn't happen to me. And if so, my husband can drive me. So we want to personalize their experience and share as many of the survivor stories and successes that we can. Heart Hero concept, working with EMS providers and talking with schools, because we know that children are really good at busting our adults when they're not activating on warning signs and symptoms and saying grandma needs some help. And then also working with EMS providers on EMS Week. Also integrating the names of the hospitals and the messaging in all of our AHA events. So the Heart Walk, there will be a huge presence there with this messaging, t-shirts, whatever, the galas that occur, the Go Red for Women luncheon. So we're trying to integrate this into all the other AHA events in North Texas. And then also CPR Awareness Week and creating a speakers bureau. So my email's there, and I know that folks are able to get in touch with me if anyone wants a copy of the slides or wants a little bit more information. I will tell you the number one question I'm getting right now is if folks outside of North Texas can use the materials. And unfortunately, that's not allowed yet because we still don't know actually if it works. So at the end of the 2-year study, our hope is that it's something we can use in every market.
That's outstanding. There have been a number of attempts at doing this, and some with mixed results. But one of the recurring things, like for instance, my wife and I helped do a heart healthy lunch program in Houston years ago. It worked beautifully for about a year, and then nobody kept it going. And so that was back in the days when the Heart Association had programmatic content. So I think something to think about. Let's assume this is fabulously successful, and hopefully it will be. What are the thoughts about maintaining the effort? Because once you stop, it'll go away.
Well, that's right. We have seen that in other studies.
Right.
Right.
So
So
maybe it's time for programmatic content to be funded annually, widely.
Well, so we'll see what happens probably the first year. Mark will start to really get good data, and hopefully if we can see these metrics change, then our hope is that it's something that we could leverage throughout our entire AHA and share with all hospitals in EMS. So, it took us a long, long time to get to the FAST campaign with stroke. AHA was really slow to put our name behind that. I'm hoping that we're flipping the dynamic and hopefully driving something that we can then leverage after the grant's done.
That would be wonderful.
Yeah.
Other questions, Robert?
do you have any recommendations to other places where they could benefit in a way that would be reasonable, that you don't have to wait 2 years and stuff like that? I understand processes and there's money invested and you want to get return on that. I totally get that. Do you have any other ideas on that for all of Texas to?
Well, I think since we do have really great regional systems working together, like San Antonio, like El Paso, and Houston, I think if the group agrees to a certain message that they want to get out, even if they don't have the money to market test it, if they come up with a single unifying statement, then they have more collective power if they've got news stations in the market, in the region, to say, all the healthcare providers in Houston really want to say, X. So it's not a magic pill, but that would be my recommendation if there's no grant funding and not wanting to wait for 2 years. I think if all the providers can agree on a message in your community, then you start talking with some media folks to see, can it be leveraged? Can you get some PSAs, and can they donate some time to multiple hospitals and EMS agencies talking about it?
But YouTube is sort of free and
Yeah.
right, to access these on YouTube, right? So they're out there now.
Yes.
Okay.
Yeah.
And
They
the other-
are out there.
The other thing that I heard another presentation on this that I would just like to mention, especially in this crowd, is that there's also that push towards educating what an EMS person does and the training and the expertise. I think that's really important because that develops a trust in the public that you're not a taxi,
Right.
that you're getting a high level of care in your bedroom. So I think that's a nice thing.
Well, we're very hopeful the data supports much more sustainable models. So, yeah.
Back in the 90s, when I was president of the Texas affiliate of the Heart Association, we had another campaign called "Feel the Pain, Raise the Flag," and it was a 911 flag. So it was a little they actually passed them out, so you raised the flag. That worked pretty well. And they had posters and all that stuff, but it didn't go anywhere because it wasn't continually funded. Any other comments? EMS providers? So can you tell us a little bit about what the EMS providers would do?
Yeah, so I will tell you, the questions we get are more along the lines of, well, what can I do with this press release? So we've got an AHA person who was hired in this, who's more of a communications expert. Her name's Erica. So Erica writes a press release and shares it that says, insert your name here. So like in Irving, they can do this in that community, or in Denton. But we get paramedic and folks calling and saying, well, do I leave my name highlighted? Do I leave the insert here? So she's walking with them over the phone and meeting with them in person on how they can put this into their regional newspaper. So I think it's just really starting to get going. So I think we're going to have more questions from EMS, just because, again, they don't have the marketing infrastructure that the hospitals do. So we're seeing hospitals also reaching out with their, with the transporting agencies that they work with to try and help them as well.
What about broadcasting companies like Clear Channel Communications and so forth? Just say, you want a PSA? Here's a PSA.
Yes, so we are doing that. So television is included, and actually, because part of the matching requirements, we're going to television, and like Univision, especially because of the Hispanic mid-acculturated group, saying if we buy 2 ads, we expect 2 more to be donated. So we're trying to take, again, the matching requirements not only for North Texas, but then in some of those regional markets as well.
Good luck.
Yeah.
Anything else? Well, we hope to see good results soon.
Thanks.
Thank you.
Thanks.
So, how many of the committee members have looked over over Bobby Greenberg's treatise on trauma care? Nobody. Nobody? I distributed it. Yeah. Send it out before the November meeting. Yes, before the November meeting. All right. So we have, I think perhaps what I might do is I'll go through it, distribute it again, and then assign everybody a chapter or something like that. So with considerations, the mere title of it is somewhat interesting. It's the strategic plan for the EMS trauma system. So since only about 20 to 30% are trauma runs, as I understand, is that right? I'm getting a nod here. Todd?
That sounds about right.
Sounds about right. And about 30, 40 are cardiac, maybe, something like that. And then there's probably 10, 15 stroke, and then some pediatric runs, and then there's non-STEMI or non-cardiac medical, COPD, exacerbation, whatever. So it seems to me the title ought to be expanded somewhat. So acute cardiac care, acute care systems, I don't know, Jamie?
Yeah, so, yeah, I mean, whether acute care or to fold some of the other important ones into it. I think you have EMS, which is clearly it could be emergency medical services and acute care or cardiac, stroke, and trauma. I mean, I think including all three of them makes some sense. They're all big enough and important enough to be part of the document, I would suggest.
So, can you all think about the title? So I was actually it was being kicked about to just emergency care systems, EMS emergency care systems. But I was told that trauma has a separate funding line, and so that you might want to include trauma so that we can benefit from that. Jane, is that right? Jane says yes.
No, Jane did not say yes. I'm sorry, what was your question again, Dr. Smalling?
So we're talking about Bobby's little booklet, the 2002 document entitled "A Strategic Plan for the Texas EMS Trauma System," and we're supposed to revise it, supposedly. And we were talking about titles and whether it ought to be the EMS acute care system or add in trauma and other things as well, and so forth. And so one of the proponents of leaving trauma in mentioned that there were separate funding lines for trauma and emergency care. Is that correct?
Yes.
Yes.
That's correct.
So therefore, leaving trauma in. So you guys, can you think about the title in addition to your assigned chapter? Okay. So I'll distribute that. Okay. So the THAC initiative report is supposed to be given by Dinah. I don't think Dinah showed up yet. No? Do we have a volunteer for that, Dr. Mixon? Okay. You want to describe THAC as chairman?
Okay.
And what's on the agenda for right now?
Okay. So the Texas Heart Attack Coalition is a coalition of various individuals as well as various organizations that are involved in cardiac care around the state, including such organizations as the American Heart Association, the Texas chapter of the American College of Cardiology, Texas Hospital Association, Texas Medical Association, as well as a lot of individuals. And we've been talking for the last almost a year about proposed legislation that could advance STEMI care and acute cardiac care in the state of Texas. And through all of these discussions, we identified a number of areas of priority. I don't have those in front of me, but I will try to recall what those are. One of the things that we've mentioned about already is ECG capabilities. Some EMS agencies don't have adequate 12-lead machines. Some maybe are not utilizing those well, transmitting those well, communicating those well. So part of our recommendations are for enhancing the equipment aspect of things. Data acquisition, which is really already underway, but there are some gaps in the data And so we addressed some of the aspects of data, recognizing that systems of care are different in different locations, in fact, vastly different in different locations, and that the regional advisory councils are really probably the best mechanism to, as Dr. Wozniak said, promote communication among hospitals and EMS and referring hospitals. So we're looking to provide funding for RACs, and that's one of our recommendations, enhanced funding specifically to deal with cardiac issues, of which the RACs are not really significantly funded at all right now. And then I believe the last piece was educational initiatives, particularly for EMS groups, but hospitals, nursing, whoever, we can benefit in that way. And so there was a lot of broad support for these areas. There were other things that were discussed. A lot of the other areas that were discussed, many of them were good ideas, but there wasn't really uniform agreement that everybody could support those things, and so we tried to reduce it to issues that we thought the broad coalition could support. So I guess about a month and a half, 2 months ago, this was all coming to maturation, and we were beginning the process of what would it actually look like to create legislation or some sort of funding bill, different mechanisms, different avenues of which we could pursue. And it was about that time that we were talking more with Dr. Neil Rutledge, who, as we've already heard from the Texas Council of Cardiovascular Disease and Stroke, they have already pursued funding, and they approached us to say perhaps we could, the Texas Heart Attack Coalition, that is, that perhaps a lot of the things that we were asking for were in line with things that they were also pursuing. And so we began to explore the possibility of the initiatives that were being set forth by the Heart Attack Coalition, sort of piggybacking alongside the rider request of the Texas Council of Cardiovascular Disease and Stroke. So I think that really kind of brings us up to date on where we are right now. There's still a lot of discussion, still a lot of unknowns about what that will look like and exactly how that will be worded. Their particular rider request includes more items than the Texas Heart Attack Coalition was necessarily interested in, but were not necessarily things that conflicted with initiatives that the Heart Attack Coalition was pursuing.
In looking through all of, there were initially discussions about certification of STEMI centers analogous to what's done for trauma systems. And when we got the data back of the surveys that you've been hearing about, it was quite clear that the mature STEMI systems, which are, at least 134 of the 150 some odd centers were doing quite well, and trying to make it mandatory that for them to do things that they were already doing didn't seem like a reasonable strategy, at least at this point. But what did jump out at us, the pre-hospital piece, the rural STEMI areas, EMS equipment and transmission capabilities and so forth seemed to be a sweeter spot. And then education, as they're doing with Caruth, would be an important issue. So those are the shift in focus of the discussions that's occurred. Robert?
Just something to add, as a member of that committee and having a lot of interest in getting something accomplished, and not being really a veteran at the legislative process, it's been described to me that legislation's kind of like making sausage. A lot of stuff goes in there, and you ultimately come out with some sort of product. And with that said,
a tasty product is what it was described as.
A
tasty product. The sausage would be tasty at the end.
Tasty. Oh, okay. Okay. We'll work on our delivery here. our timing is off. But the point I would make is this: just like we talked about the version 1 of the data that's so important for us to have, there are a lot of people, whether you're watching from some faraway place or here physically, that you may have a better understanding of the legislative process, you may be better connected, and I would just ask you to become knowledgeable, don't be skeptical, because a lot of times when you're thinking about legislation, money, there may be the negative slant on it, but I would ask for support and getting involved in trying to ask about what you and your area, your community, because this is raising the level of STEMI care. And it may not be everything that everybody wants, but it's going to hopefully be something that will move the ball forward in your community, that you could tangibly get some results if you actually get involved. So as it gets to the point where we need support, it's a grassroots support, and that's what I just beg people to. It's time. It's time. You got 2 months, 3 months here. It's showtime right now.
Anything else? Jamie?
No, I think yes.
Covered. Okay. I think we have some time for public comment. If anybody else feels the need to get up and chat about something, feel free to do so.
So since Caitlin Murphy is not able to be with us today, she's our government relations director for AHA, for American Heart Association. I did want to share 2 talking points that she asked me to clarify our priorities and to make sure that, so for folks who follow the minutes for this committee who aren't able to be here know where we stand on some of the legislative priorities. So want to make sure to state that the American Heart Association will not pursue legislation mandating designations for heart attacks this legislative session. However, we would like to see a full system of care in place for the state of Texas, and we'll continue to look for policy needs that fit the needs of our stakeholders and our state going forward. And then secondly, from the data collection initiative from that DISHES is conducting right now, the American Heart Association is focused on protecting those dollars for the Texas Heart Attack and Stroke Data Collection Initiative. So towards that end, we're going to be advocating to make sure that those dollars are preserved and, if possibly, increased. Thank you.
Thank you very much.
Hey, Wendy, I have a question. Sorry. Are there states where the American Heart Association has pursued levels of cardiac designations?
You know, that's a better question for Caitlin. I'm sure there are. I don't know how many were successful. So I'd have to ask Caitlin. I can get you that number, and if you would like me to send that to the committee, I can do that.
I would be very interested.
I will say that, as Dr. Smalling mentioned, we do have considerable opposition to mandating that. And actually, the item that we don't have a good answer for is if we have so many hospitals voluntarily submitting data and going through the accreditation process, why mandate it? So we know, we as American Heart know that it still provides the best patient care, but I think we still have a number of folks who aren't on the same bandwagon yet.
I would like the information, because if it was mandated and it did not work well, that would be great information for us to have.
Sure, I'm happy to send that. And Jane, would it be easier to send that to you so it can go out to the group?
Or I can send you the contacts we have.
Okay, that would be fine. And I'm sorry I don't have that answer for you, but like you've heard, Dinah's on the Hill, or, down at the Capitol, and so is Caitlin. So, thanks.
Thank you.
Could I add just one comment about that? I recognize that the designations are dead at this point and a third rail potentially politically, but Texas does have designations for both stroke and trauma facilities, and perhaps what separates cardiac is the amount of data that's already publicly reported and the amount of data available, but still the third-party independent verification to help hospitals improve has proven itself in other fields, and I still think someday is something that we may want to consider, but I recognize it's not realistic now.
Not this biennium.
Yep.
Yeah. Well, we started late, and it's a little bit even earlier than our regular schedule. So unless anybody has any further burning issues, then I think we could consider this committee meeting closed. Thank you very much.